Okay, well, I'm going to start kicking us off, and hopefully, in these next few minutes, some more folks will be able to join. I can see people are still coming online. Well, welcome. I'm Bianca Frogner. I am a professor at University of Washington, and I direct the Center for Health Workforce Studies. I am also part of the leadership team of the Award Network, and I host the webinar series. I'm really glad to see many of you join, and we are excited for our speaker, Joan Carpenter, who will be speaking about pragmatic clinical trials for people living with dementia and their care partners. But before we hear from her, I'm going to just remind folks that, as always, we want to hear from you about about webinars that you want to hear about, and so you can scan that QR code, and there's a link there to share with us your ideas. And also, you can find all of our prior recorded webinars posted on our website. So please go and check that out. Let other folks know that there's a whole library of webinars there for folks to listen to. This one will also be recorded and will be posted shortly after this presentation. Next month, we have Kim Powell coming to join us to talk about telehealth implementation in nursing homes with a focus on rural communities. So put that on your list and let others folks know about this one coming up. Hopefully you have heard about the National Dementia Workforce Studies Pilot Grant Program. They're on their second cycle, and so they're accepting proposals through April 28th. You can ask for about 12 months of funding, up to $160,000 in total costs, $100,000 in direct costs. So don't miss that opportunity. You can learn more from our website. Oh, sorry, I realize that the website is wrong there. But we will certainly make sure to send out the correct link. And if you aren't already on the National Dementia Workforce Studies listserv, certainly sign up for that. The webinar series here could not be done without the wonderful volunteers that are part of our webinar committee, including Jin Jun, who will be our host for today. We have cycled off a few members and are bringing on some, we've cycled off some old members and who are moved on to doing other volunteer activities for the Award Network. And we're cycling on a few new members, including Roy Thompson, Kira Rice-Skina, and Kate Brown. So you'll be seeing and hearing from some new voices. And if you're ever interested in participating in the Award Network in any leadership way, please don't hesitate to reach out to me or Joanne Spetz, the PI of the program. And we'd love to always get new folks interested and engaged in our work. I want to acknowledge our leadership committee, again, led by Joanne, and we have a wonderful team who makes all these activities happen. And then I want to acknowledge the funder, NIA, for supporting the Award Network. And of course, the views expressed in this material does not necessarily reflect the official policies of NIA. Okay, with that, I'm going to turn it over to Jin, who is our host for today. So thank you, Jin.
Afternoon or good morning, depending on where you are. Thank you so much for being here, and I'm excited to introduce my colleague, Dr. Joan Carpenter. So my name is Jin Jun, as Dr. Frogner mentioned. I'm at the Ohio State University College of Nursing. And today our presenter, Joan Carpenter, she's an associate professor in the Department of Organizational Systems and Adult Health at the University of Maryland School of Nursing. And she's a board-certified advanced practice nurse in hospice and palliative care. And Dr. Carpenter has over 2 decades of experience working with individuals facing serious and complex illnesses, including dementia. Her research focuses on improving access to high-quality palliative care in nursing homes and post-acute care settings, particularly for those living with Alzheimer's disease and related dementia. Dr. Carpenter's work has been funded by leading organizations, including the National Health the NIH and the Veterans Health Administration and Maryland Higher Education Commission. She serves as a principal investigator on multiple studies exploring palliative care implementation, telehealth innovation, and decision-making support for seriously ill veterans and nursing home residents. She uses interdisciplinary collaboration to test evidence-based interventions that enhance the care quality and align treatment with patients' goals and preference. In addition to her research, she's an active leader in the field of gerontology and palliative care nursing. She has contributed in national committees, served on editorial boards, and played a key role in shaping the research agenda for hospice and palliative care nursing. She's received numerous honors, including New Investigator Award from the Hospice Palliative Care Nursing Association, and she's committed to mentoring the next generation of nurse scientists. And she's accepting PhD students so at the University of Maryland, so if anybody knows. And with that, I'm gonna turn it to Joan and share her exciting work that's happening. Take it away, Joan.
Thanks, Jen. Appreciate that really kind introduction. So as you mentioned, yes, I am a by background a palliative and geriatric nurse practitioner. All of my work really stems from the clinical experiences that I've had working with patients and their families in nursing homes. I want to start today by starting with a poll question, if we can put the poll question up, because we are going to be talking about pragmatic clinical trials. I'm curious, have you conducted a pragmatic trial with people living with dementia and or their care partners? So just answer question number one right now. Let's see. We can just see how many folks we have here joining us.
We have about 7 people, Joan, other than the panelists here. So there's about 13 in total. But I think we can't vote as panelists.
We can't vote. Okay, well, and for any of you who are going to be watching this webinar afterwards, be thinking about this question. Have you conducted a pragmatic trial, or are you familiar with a researcher who's conducted a pragmatic trial? So I'm not able to see if there are any responses. So I'm not sure if you are Bianca.
I can't, but maybe Kat can go ahead and close. Kat?
Oh, there we go. So close, yeah. So it looks like no. Okay. Oh, and then, oh, good. Some people did answer question two. What are you most interested in? I'm not sure what the short answer is, but we can talk about that afterwards. How about that? So nobody's conducted a pragmatic trial for people living with dementia, and that is not an uncommon finding. That a lot of folks actually haven't had the opportunity to participate in a pragmatic trial, or really to fully understand what pragmatic trials are and what we use them for. I'm going to start by talking first about our objectives today, which I want to talk about the NIH stage model for intervention development, also identify the important elements of explanatory and pragmatic clinical trials, and then explain. I'd like at the end of this for the participants to be able to explain the clinical trials research continuum for intervention testing, and I will be using an example from my program of research, working with people living with dementia. So we'll start with the NIH stage model, and this is a conceptual model that supports intervention development. Ultimately, we want interventions to be maximally potent and implementable. So it provides an approach that research can identify, define, and clarify all of the activities that they need to engage in during intervention development. It facilitates the scientific development of interventions so they can be implemented, and there are several stages of intervention development that are identified. And we'll talk a little bit about those in the next slide. The NIH stage model also helps researchers to adapt an intervention to various real-world settings. And it helps researchers to consider the intervention's ease of implementation. And thinking about that as early on in intervention development is important. How is this intervention going to be implemented in the activities either of clinicians or patients, so that they are able to use the intervention. And there's good uptake and scalability. So the ultimate goal of the NIH stage model is to help researchers to create an implementable intervention to improve health and well-being. So what I talked before about was the several stages within the stage model, obviously. And stage zero is really where basic science occurs, and this is before intervention development. It's super relevant to intervention development and ultimately translatable interventions. It also is this stage where we start to, look at mechanisms of change. What is it? Asking basic questions that, how do people change behaviors, or how do we change behaviors that are relevant to the intervention? In stage one, this encompasses all activities related to the creation and testing of a new intervention. It can include generating new interventions, as well as modifying or adapting interventions, even refining them. That's stage 1A. And ultimately, you want to test that intervention, right? Feasibility, using, feasibility and pilot testing in stage 1B. Again, you can modify your interventions during this stage, and developing training materials as well for an intervention can occur during this stage. Stage one studies can occur in research settings with research providers, or in community settings with community providers. Moving to stage two, what we call pure efficacy research. This is where experimental testing of promising interventions occurs in research settings with research-based providers. So it's very controlled environment. In stage three, moving more to what we call real-world efficacy research, where there's experimental testing of interventions in community settings with community providers. You attempt to maintain a high level of control, right? So we want to maintain internal validity in stage three, but we also want to see, what is happening in the community outside of the controlled research setting. So sometimes people call this a real-world efficacy stage. In stage four, moving to effectiveness research, where we look at an intervention that's been empirically supported, and we want to test it in a community setting with community-based providers, and we want to maximize the external validity during this stage. So we want to say, do the study results apply to similar patients in different settings? Is this truth in real life? Is this going to work in a real world setting? Is this intervention going to work there? Pragmatic trials or stage four trials. And then stage five is the implementation and dissemination phase, where this research examines the strategies of implementing and adopting empirically supported interventions. One thing to remember about the stage model is it's not prescriptive, and it doesn't require that researchers complete each stage in a specified order. You may find you go from stage one, developing an intervention, to stage three, testing it in a community setting, or and maintaining internal validity. But being able to go to stage four really requires that you have the efficacy data. You know that the intervention does provide the effects that you want to see. And again, you may go back to stage two to do some modifications with an intervention. So moving on, and I borrowed this slide from my good friend Casey Jackson, who I think is here with us today. This helps researchers to think about whether their research is explanatory or pragmatic. So when I talk about explanatory research, I'm thinking about efficacy research. So pragmatic research gives us the opportunity to see what research will be like in the real world setting. And as you know, a randomized clinical trial doesn't always behave like the real world, right? A really tightly controlled trial with tight inclusion exclusion criteria, with extensive data collection for the primary clinical outcome, with really frequent follow-up times. That doesn't always look like the real world and how we would treat patients in a real world clinical setting. So remember, pragmatic research is more looking at the effectiveness of an intervention in the real world setting. So does this intervention work under usual conditions? An explanatory clinical trial would be effectiveness in a controlled setting, or efficacy in a controlled setting. Does the intervention work under ideal conditions? Again, tend to be a little bit less flexible and more restrictive. I like to look at clinical trials along a continuum. And the continuum ranges from traditional explanatory trials that aim to explain a cause and effect, while controlling for many factors, to pragmatic clinical trials that test how a treatment or intervention affects a patient in the real world, counting and thinking about how do you optimize that intervention within a very busy and diverse clinical setting. And in order to make design choices for explanatory and clinical trials along this continuum, there's a tool called the PRECI2, and it's a validated tool that can help researchers make decisions about the design of a trial and match that to the overall purpose and intent of the trial along this continuum. So it encourages researchers to really be deliberate about the decisions that they make in the design of a clinical trial. So here I have an adapted tool from the original publication listed here. And a trial, there's these 9 domains that are within the PRECI 2. And a trial can be more explanatory with pragmatic elements or more pragmatic with explanatory elements along these 9 domains. So, for example, in recruitment, thinking about how are participants recruited into a trial, how much extra effort is made to recruit them over and above what would be done in a usual care setting. And eligibility, who's selected to participate in the trial, to what extent are they similar to who would receive it if it was part of usual care, or are there really tight inclusion and exclusion criteria? So many people are excluded from receiving the intervention. In the setting, where is it being done? How different is the setting where the trial is being conducted from a usual care setting? Is it a highly controlled environment, or does it look more like the real world clinical setting? In the organization, what kind of expertise and resources are needed to deliver an intervention, and how different are those from what would be in usual care? Flexibility in delivery. How should the intervention be delivered? How different is the flexibility and how it's delivered from the flexibility anticipated in usual care? So again, this is like along this range here, and I'll explain to you in a little bit from 1 to 5, that the lower scores, so a 1 is highly explanatory, whereas a 5 is highly pragmatic. Flexibility in delivery. How should the intervention be delivered? How different is it? I think I said this than in what is in usual care. And the flexibility and adherence. What measures are in place to make sure participants adhere to the intervention? And how different is that from what would be anticipated in usual care? One of the things that we like to talk about with flexibility and adherence is, a patient who may need to adhere to a medication in the real world. Patient may not take the medication at the same time every day. There may need to be some flexibility in that adherence, but in a tightly controlled trial, that medication may need to be taken at the same time every day. And follow-up, how closely are participants followed up? And how different is that intensity of follow-up to what's in usual care? And then the primary outcome, how relevant is it, and how much data needs to be collected outside of what is collected in usual care for that primary outcome. A highly pragmatic trial would collect most of the data from the electronic health record for the primary clinical outcome. And then the analysis, to what extent are the data included? Do you exclude those participants who maybe did not complete their final follow-up data, but may have completed, baseline 3 months and 6 months? Whereas using an attention to treat analysis, where you include everybody that participated in the trial in the analysis in a more pragmatic manner. So you use the tool, as I started to explain before, by scoring the choices that you make on the wheel. 1 is very explanatory, 5 is very pragmatic. So you have a range there. And then you review your set of the 9 choices. And I'm going to take some time now and talk to you about first an explanatory clinical trial and a pragmatic clinical trial. So as I explained before, highly explanatory trial would mean to maximize the intervention's chance of demonstrating an effect. Little attention is paid to whether the outcome would be achieved under real world conditions. So these trials are unlikely to establish effectiveness under everyday conditions. But again, as I said before, you have choices to make along the continuum of the explanatory and pragmatic trial continuum along using the PRECI 2 wheel. So this is a study that I completed several years ago, highly explanatory clinical trial. We were developing and testing a dementia palliative care intervention in a nursing home, really stage 1A and 1B. So in 1A, we developed the intervention. We received feedback from specialists, palliative care specialists on the intervention. And then it culminated in feasibility and pilot testing in a nursing home. So the red diamonds or the red triangles on this slide show the along the continuum of pragmatic, explanatory to pragmatic, where my choices were made. So in recruitment, we used extra resources to recruit. We had study staff actually in place helping to recruit for the study and making sure that participants were eligible. And we only chose those participants who had a diagnosis of dementia that was advanced, had a caregiver present and available for participation, and then also excluded those who were on hospice care or would be considering hospice care in the future if there had been maybe a consult for hospice to be involved. Um, Again, well, the eligibility, we had tight inclusion criteria, as I just mentioned, um, and we did not include everybody that came into the facility with a dementia diagnosis. In this setting, it was one center. It was very specialized, and it was not it was a community nursing home, but it was one particular place that had a dementia care unit, had access to a specialist palliative care provider, and so we're able to participate in this study. And the organization, thinking about the match between how care is delivered in the trial, how it's unusual care. Again, in this particular setting or organization, there was a specialist provider who could deliver this intervention. That does not look like every nursing home throughout communities and different regions and states. The delivery, again, this was a more explanatory trial, so we had a highly protocolized intervention with a tightly defined delivery timing window within 3 days of admission to the facility. And as I mentioned, there were some restrictions on other types of care that the residents were receiving. Adherence, again, there was a strict protocol for how to measure and maintain fidelity in this trial. This would be less like the real world where clinicians can use their clinical judgment during an encounter. On the analysis, we only included those patients who actually received the intervention, which is important, but also we only included the residents and their care partners that completed all of the outcome measures as well. And follow-up, again, more intense follow-up. We had data collection at several time points immediately after the intervention was delivered. And I'm trying to think if when we did follow up, we collected the data ourselves as the research staff. So we weren't collecting it from the electronic medical record. And then the outcomes, in explanatory clinical trials, oftentimes you're collecting outcomes that the researchers are most interested in, not necessarily what we would measure in usual care. We had extensive data collection tools using validated and reliable measures, but they were not integrated within what would be usual clinical care. So end of life satisfaction with end of life care was a 15-item tool, and that's not something we would implement in usual care, but it was important to us as the researchers for this particular trial. So in contrast, at the other end of the spectrum, a highly pragmatic trial would be designed to maximize the applicability of the intervention to usual care settings across a range of settings. It's focused on care in the most common settings where people receive healthcare. And so this is another trial that I designed that was more of a pragmatic trial. And this is the Pressy tool where I made design choices using the Pressy tool for a more pragmatic trial. Again, this is a continuum, explanatory to pragmatic. So this is leaning a little bit more toward pragmatic. And this trial was focused on people living with serious illness, including dementia. We received a supplement for people living with dementia. And we aim to enroll people living with serious illness and dementia in this palliative care intervention on admission to a nursing home after hospitalization. And so in this trial, we identified subjects within the nursing facility. So the nursing facility actually, the social worker and the staff could actually identify the newly admitted residents, and or their care partners if they were unable to make their own decisions, and using electronic health records on admission. So they were helping us to identify those. And we, for eligibility, it was all newly admitted people in the dementia supplement living with dementia. So we, as long as they had a diagnosis of dementia and they were recently hospitalized, they were eligible for this study. In this setting, this was among 12 nursing homes. So it was the identical setting that we intended to implement the intervention in the real world. The facilities were urban. They had memory care units. Some had memory care units, some did not. They had different specialty services, so it looked more like a real world setting. Um, the organization, as far as this organization, it was a really fantastic opportunity because they had said the leadership within this healthcare system that we partnered with had expressed great interest in enhancing palliative care within their uh, facilities that they ran. They said the timing was excellent. The intervention was synergistic with their mission to improve care for older adults. So the organization had, bought in and was really, really wanted this to be a part of their um, culture within their facilities. And we were able to integrate a progress note into the electronic health record so that once the intervention was delivered by the nurse practitioners who were working within the organization, they would document this in the electronic health record, and it was available for all of the staff and any clinician working with the resident to see. The flexibility in delivery, the intervention delivery required minimal changes to the usual care that the nurse practitioners were providing. It really augmented the care that they were providing. We trained them in a palliative care intervention that fit the workflow and used the existing resources of the system that they were working in. Um, the nurse practitioners had flexibility in its delivery. We asked that it be delivered within the first week of admission to the nursing facility, but then documented why that may not have happened at certain times. Again, the resulting documentation from the consult was integrated into the normal workflow within the chart of the resident. Um, the flexibility and adherence, the staff had flexibility in how to engage with this intervention and use the recommendations. We did monitor fidelity to the interventions, but by only monitoring the 6 core components of the intervention. The flexibility, our fidelity protocol was not as strict as the previous trial that I talked about. We wanted to make sure they touched on each of the 6 core elements, but they had flexibility in how to do that. Again, in the analysis, all the intervention recipients, so all of the participants the resident participants in the study, data were included in the final analysis. So we did not exclude anybody. We used an intention to treat analysis. And then follow-up, thinking about, this was completely based on the needs of the residents. The follow-up time periods were based on what the nurse practitioner felt was necessary. So we didn't have necessarily scheduled follow-up. So again, much more like usual care. And the outcomes, this was a more explanatory kind of approach because we did primary data collection, collected, in the outcome data from the participants or their care partners. And we didn't use the electronic health record, but we did try to identify an outcome measure that we felt was important to residents and their care partners, which was quality of life. So now I want to talk to you, now that we've talked about this explanatory trials, pragmatic trials, I want to talk about a recent project that we conducted that focused on the implementation of a pragmatic trial. And we really wanted to look at the perspectives of the key informants, because that's really important to be thinking about, is that, we have ideas as researchers of what we want to do in clinical settings, but how are the interventions perceived, and what are the perspectives of those people who will be implementing them when the researchers are no longer a part of that system that is implementing a new evidence-based practice and intervention. So this is a study that we did implementing telehealth palliative care in nursing homes for people living with dementia. And we're going to talk about the barriers, facilitators, and adaptations that were recommended by key informants. I just want to acknowledge that this and a lot of the work that I talk about today has been informed by my work with the NIA Impact Collaboratory. The website's included here. Highly encourage you to look at this website for training modules, for tip sheets, lots of resources, videos that you can go and explore. And I believe that you have in the um, in your seminars that you have had a presentation about the Impact Collaboratory in the past. So, what we know is that telehealth consults have been incorporated in nursing homes for a while, for over 2 decades, and to help increase access to care. It can be critical, actually, for specialist services like psychiatry, dermatology, neurology. And there is some evidence that shows that it's feasible and acceptable and efficacious in its ability to deliver the same outcomes as face-to-face visits for palliative care, geropsychiatry, and chronic care management. It can actually be particularly effective for reducing acute care use among nursing home residents. But additional support for telehealth is in the research that describes nursing home residents, staff, and family acceptability of its use. But it's unclear how to best implement and adopt as well as sustain these types of services. So despite its potential benefits that I reviewed, research shows that there are challenges with using it, and that can be unreliable video connectivity, difficulty with device setup, troubleshooting, technical issues. And further, in a pilot study that combined palliative care specialists via live video with case-based nursing home staff teleconferencing, a high percentage of family members reported they'd prefer to see the healthcare provider face to face. So that's concerning because even though we may find that the outcomes, if we're studying maybe hospitalizations or, you know, these outcomes that are important to the researchers, that maybe the family members and the residents who are involved in the telehealth aren't as satisfied with their care. So, due to these challenges and in both integrating telehealth and mixed opinions on its use, we sought to understand the perceptions of key informants involved in nursing home telehealth, specifically when it's used for people living with dementia. So we aim to explore the views of palliative care providers, residents, families, care partners, and dementia advocates regarding the barriers and facilitators to adopting a telehealth palliative care intervention for people living with dementia. And this was during a pragmatic pilot clinical trial. It was a single arm trial aimed to enroll 30 people living with dementia in one nursing home with pre-existing telehealth services 24 hours a day. So this was a part of their usual practice. They had telehealth there. It was primarily used for primary care and acute care needs. So we were adapting it for palliative care. Again, we had broad inclusion criteria. The participants, or we did include those over 60 with a documented dementia diagnosis who were recently hospitalized, and they were being admitted for post-acute care. Again, the inclusion criteria were purposefully broad because people living with dementia may exhibit symptom distress and complex needs after hospitalization. Again, we wanted to make this look like the real world. So for this particular study, this particular analysis from the study, we collected data from August of 2021 through December of 2022 using focus groups and interviews. And mostly because of factors related to COVID-19, we had to use that combination of different ways of collecting the data. And this study was guided by the REAIM outcomes framework. And we're going to talk a little bit about that on the next slide. Let's just jump to that now. It was guided by the REAIM framework and the PRISM framework. And what we wanted to do was look at these three factors within the PRISM framework: the perspectives, characteristics, and implementation infrastructure, how that affected the implementation of telehealth palliative care, and then look at the REAIM outcomes. REAIM model is reach, effectiveness, adoption, implementation, and maintenance outcomes. We only looked at reach, effectiveness, adoption, and implementation outcomes in this particular analysis. We did not look at maintenance. It was really outside the scope of the study. So the interview prompts, as I mentioned, we used semi-focus groups and semi-structured interviews. The interview prompts were guided by the PRISM. And what we wanted to see let me see where I'm. Oh, sorry. We wanted to see from the perspective of the key partners, what were their perspectives? What did they think about the implementation? What did they think about the infrastructure and the sustainability of this? So we also used the REAM framework to guide the analysis. We wanted to we wanted to understand the perceived need for the intervention. We wanted to know what were the most and least effective components, including outcomes that were really important to the participants. So what would they think was important to show that this was effective? We wanted to understand its acceptance and any adaptations that the participants thought that we should implement, and also the barriers and facilitators for its uptake. So, as far as the results that we learned about during this study, we found that the barriers far outweigh the facilitators for uptake. In general, there were implementation barriers that included stigma surrounding dementia, palliative care, and nursing homes. All three of those things. Specific to telehealth, the barriers were reported were multiple logistical pieces required to implement it. There was inflexibility at times of both the palliative care provider and the nursing home staff, that each felt the other may have had some inflexibility. There were competing priorities at the nursing home. And really the inability to assess the resident in person seemed to be a barrier for the palliative care nurse practitioner, which is somewhat similar to what we heard in the introduction that I told you about, that we had found in some of the research that there were families that really preferred to see a provider in person. As far as the facilitators, participants reported that telehealth could reach people living with dementia in a nursing home earlier in the disease course, and we thought that was a really important finding. It also could reach people who otherwise lack access to palliative care services. Um, the staff did report that the telehealth usability, that it was usable, that it was easy, and it was an easy platform to use, and that they were familiar with it, so that helped. And one of the other facilitators was having nursing home staff or a family member present. And interestingly enough, in the adaptations, that is one of the suggestions that the nursing home staff made, was that having family present during the visit, for the visit, fully involved in it, to help with the logistics at the nursing home would be helpful, mostly because of the staffing issues that they sometimes ran into. The one other adaptation that we were informed of was that there needed to be stronger nursing home advocacy for palliative care, that we really needed to do better assessment of the organizational readiness for change within the nursing home. And there was a lot of suggestions around dementia specific and palliative care education to increase the uptake, so that whenever you approach a person, potential, with the idea of palliative care, that they understand what that is and they don't conflate that with hospice care. So the next steps, we learned a lot from these three different studies that I've told you about. This last one that I shared with you, this has really focused my work over the past 3 years with the Betty Ivory Moore Fellowship for the Nurse Leaders and Innovators, which has funded a project where we are doing a large comprehensive qualitative study to better understand these barriers and facilitators to palliative care for people living with dementia and other serious illnesses, and also to develop a theoretical model that reflects these relationships between these constructs, these barriers, these facilitators, and how we can overcome them so that we can effectively implement palliative care in nursing homes. And then lastly, also to really dig deep into these outcomes that are important to the people who are receiving palliative care consultations and those who are delivering them, so that we can best align what we believe are the outcomes that would be most valued with the theoretical model that's the palliative care that's being delivered. The last thing I want to leave you with before we get into some questions are resources. So the first link is a living textbook on clinical trials, pragmatic clinical trials. Highly encourage you to check it out when you have a chance. Also, the NIH stage model reference. And then I want to share with you the Next Steps program. And for those of you who do nursing home research, this is a really great opportunity. This was established in 2024 with funding by a cooperative agreement from NIA. The goal is to support high quality research by advising on research design, disseminating best practices, and sharing findings with those who can use them to improve the lives of nursing home residents, their families, and staff. So the intent of funding the funding within Next Steps is for pilot projects to support investigators in their efforts to obtain preliminary data. So they can actually use that preliminary data to conduct explanatory clinical trials in nursing homes. So in addition to receiving funding, awardees have access to relevant curriculum. They receive input from experts to help their research skills and ensure successful project completion because nursing home research can be extremely challenging. So I'm a co-investigator on this grant, a part of the Pilots and Training Corps. And currently there is an RFA out for the pilots. And I think the due date is in April with funding announcements in June. So with that, I'm going to stop sharing my screen. And Jen, I will let you coordinate some questions and discussion.
Sure. Well, thank you for that wonderful presentation. I do see one question. This is, so I don't remember which slide number it was. I think it was early on. William asked about the category. Oh, he found it.
Well, I
The
can get it. I can also looking. Oh, I see it. I can put it in the
uh,
chat.
yes, that would be great. And
Yeah.
at this time, I will open the floor for anyone that may have questions related to either pragmatic trials or even telehealth palliative care in nursing homes.
Maybe I can ask a question here. And Joan, I realize that the citation that's posted in the chat can't probably be seen by our audience. So we can certainly get that out there. And just to note that it is a study in BMJ 2015 led
Yeah,
by Loudon, the
you got it. It looks
procedural.
like, yeah, it looks like the person who was asking for it found it. So perfect. I'm
Great.
glad.
I'm curious, Joan, thank you for that presentation. It was really interesting kind of to hear the side-by-side of pragmatic trials versus explanatory trials. And I'm just curious from your perspective in this world where I think there's so much emphasis on RCTs, how well pragmatic trials are being accepted and how are people taking in this information? Because you can see this audience, it's still a new tool or it's a new way of really thinking about studies. So when you communicate out results and try to explain pragmatic trial results, do you ever encounter like pushback or questions about how it compares to, say, the gold standard of the RCT?
Yeah. So it's such a good question because one of the questions that I sometimes ask audiences is do you think pragmatic trials are less rigorous than explanatory trials? Because this idea of like loosening up a little bit or having some not be as tightly controlled because we think, well, if we don't tightly control for a cause and effect, then we can't say what actually caused our outcome. So I think this is where when you justify your choices, when you think about, when you're designing a trial and you're saying, okay, I want to make sure that this is going to work in the real world. What do I need to make deliberate choices about that will maximize the external validity, right? Like, so say the cluster randomized controlled trial, right? So like for me in nursing homes, I actually have to do cluster randomization, not individual randomization. So most pragmatic trials are going to use cluster randomization as well, assign units to the intervention. Um, so I think where I'm going with this is thinking about the choices that you made and justifying those choices and looking at the the potential trade-offs, that what are the reasons that you made that choice for a broader eligibility criteria, because that then is going to be better representative of the population that will use that intervention down the line. So, I think that using when go to the Prezi tool, actually, the article that I put there has great information about making those choices and then justifying them. As we know, that's so much of what we do in science, but it's not that they're less rigorous. It's just controlling for what the different elements that you're able to control for. There was a large pragmatic trial that was done, and they found that and it was an advanced care planning tool. Um, and they found actually fidelity to the intervention was quite low. And so that was something that they needed to address, in future iterations of the trial. So, I think it's those types of things, and again, like I said, in this one trial, we looked, did the nurse practitioners adhere to the six core elements? Not did they do everything within those six core elements, because they had to make a choice of what to do within that. So one of the core elements was follow up, for example. And some of the elements of follow up would be refer for hospice services, schedule a second visit. Sometimes they didn't do that because it wasn't appropriate for that particular participant, but they addressed follow up. They said no follow up needed. So for us, that was like, okay, they adhered to that element the of the protocolized intervention. So I hope that helps explain that.
No, that helps a lot. And then it makes me wonder, maybe because my sense is pragmatic trials are growing and that literature, that body of literature is still, it's emerging, although it seems like it's been around for a while. How many, have people gone back to compare outcomes and how different they are in pragmatic trials versus other types of methods for some of the same topics, maybe in your field or otherwise? Have you seen some good examples of how or whether people have done those kind of comparisons of outcomes from these different kinds of trials?
So I'm not sure if there's been comparison of outcomes, but what I'll tell you is that we know in pragmatic trials, we're trying to collect our outcomes from the EHR. And there's an article that we wrote not long ago, a scoping review on like what are the outcomes that are collected in electronic health records, in published studies, and how pragmatic are these outcomes, right? Like how easy are they to get to? Primarily, you're going to find rehospitalization. You're going to find, was a most form, or a state authorized portable order for life-sustaining treatments, was that completed, or billing data. So, that's part of it, is how do we integrate measures in the electronic health record or routinely collected data that are meaningful to patients and their caregivers and care partners, and particularly people living with dementia. And then, so when you say comparison, because pragmatic trials tend to collect those data, and explanatory trials typically collect, primary outcomes from the participant, it's hard to make those comparisons. So I don't know that I can say comparisons are done like that.
No, but I think it makes a lot of sense in a scoping review, like you said, like you're going to have a certain subject that you're trying to figure out some outcome for some particular group of people, and you're comparing as part of that scoping review, what are the different methods by which they try to find those associations? And pragmatic trials may be one of those approaches by which they tested out that relationship. So I think that makes a lot of sense.
Mm-hmm. 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 For sure. Thanks for that.
I think some of us were probably thinking the same question, because one of my questions was exactly what Bianca just asked. I just want to see if there are any other questions from the audience or from even the panelists.
And I'll just note, Joan, that we did get the open-ended responses, and it seems like you probably pretty much addressed that question of what they wanted to know. So one is just how to approach pragmatic trials, some examples on how to do pragmatic trials. Maybe we could get some more clarification from some of our audience members, but there was a comment that they want to understand dyadic data collection, inclusion, and screening. and someone else wanted to know a little bit about compliance. So it's kind of a open-ended
Yeah.
notes, but I don't know if you have
Yeah.
comments just in reflection to that feedback.
Dyadic is so interesting. Like trying, yeah, pragmatic because okay, so when I think of dyad, I think of the and I'm just going to use the word patient and care partner, right? I think the patient and their care partner, and typically in the EHR, when I'm talking about pragmatic trials, we have data on the patient in the EHR. We don't necessarily have data on the care partner in the EHR, right? So this is one of the challenges with dyadic research and pragmatic trials, especially with, when you're thinking about a health system, is how then do you collect those data on a care partner? And so unless you're using a really robust EHR that has, that, and then you may be able to implement some measures or implement something that the care partner then would fill out right within an electronic health record. I think about like like you look at my parents EHR, and I'm in there, and do I get prompted with a questionnaire, right, that I fill out as the care partner? Am I having difficulties? Is there some? But then that requires there's so many and this is actually this is a tool that you can find on the Impact Laboratory website. It's a webinar type of it's not really a webinar, I should say. It's like a training series. It's actually a certificate, a health equity certificate that we developed, where you can actually watch these different videos and better understand kind of what are these challenges in making sure that you are reaching the population that you're most interested in, and that if you're using an EHR, are they engaging with the EHR? Not everybody has that savviness with electronic health records and with technology. So there's challenges there too that set us up maybe for not including the entire population that we want to be a part of our study. So
Point. Yeah,
thinking about the screening is interesting. Yeah.
yeah, I can certainly see the challenges that come along with that. And how about issues of compliance? Are there certain things that people should consider or be aware of?
I'm wondering if that's a question about institutional review boards,
Yeah, that's what
and
I'm wondering too.
that's kind of what I'm wondering if that's a question that's about like your protocol is just as rigorous. Like when I write protocols for pragmatic trials, just as rigorous as an explanatory trial with the different our approach and our design and data collection. And so I think I will say some institutional review boards are more familiar with pragmatic research and some are less familiar. I have found that providing education and background information is sometimes helpful. I've been involved, with a couple IRBs where one IRB allowed us to use an alteration of consent using broadcast notification for consent. And when we went to another institution, the IRB required verbal consent. So they viewed it differently. They viewed the protocol and the approach to consent differently. So I think there is some education there around compliance and around, how you're making sure that, these are minimal risk studies. Um, you make sure that you're, protecting participants, and especially if you're looking at altering or waiving consent, because pragmatic trials often will apply for a waiver of informed consent because the care is being integrated into routine, usual care. And we did have a waiver on that the second study I talked about,
It actually
more
makes me
pragmatic.
wonder if some of this work can be put under the heading of quality improvement. And have you encountered questions about whether this is quality improvement versus, say, a research study? Which, as a researcher, sometimes finding yourselves in the quality improvement space has some benefits also.
Oh, absolutely. And I'm actually doing more quality improvement work now because I'm finding that we're making change faster because I don't like how long it takes to make a change in a clinical system and especially in nursing homes that need change much quicker than a lot of, they're just under-resourced, understaffed. So I guess the biggest difference is quality improvement you're going to be working within that one organization to improve care within that one organization. Whereas, when you're doing a pragmatic trial, you are actually working to generate knowledge that's widely transferable and generalizable to other settings. So I think that's probably the bigger difference is that, the QI umbrella really is going to kind of keep you within that one organization or setting. I do want to say that Casey said, um, the dyadic topic, it's good to understand about whom language. She was citing 46 CFR 46 when considering how you collect data, how it impacts the IRB's interpretation of a research participant. So that's interesting. Oh, 45 CFR 46. Yeah, thanks, Casey. So Casey is, I will say, she's the research quality manager who works with me at the University of Maryland, and she's remarkable. She's like, I go to her with lots of questions about the different not challenges, but different situations that I may be involved in and may encounter throughout the different types of research and QI work I do. So anyway, I appreciate her lending her knowledge.
This was a really good, lively discussion. Bianca, I think you read my mind because all those were on my brain in terms of
So
questions.
curious.
Well, it's 11:57, so I want to be mindful of the time. So I just want to give another 5-second pause to see if there are any questions. Perfect. And thank you for like really sharing this work. I think honestly, sometimes it's the philosophical approach as researchers, pragmatic requires, I think, innovative and different ways of thinking. So I'm really excited to hear about this work. And I think you're fabulous, Joan, so all that too. And so I think that's the end of the webinar part of today. I don't know, Bianca, if there's any other
Oh,
things
that's
that you
it.
need to
Just
add.
thank you, Jen, for coordinating this and bringing Joan to our community. And Joan, thank you so much for your very informative presentation, as others are noting here in the chat. So, and thank you to everybody who joined today. And I know this will be a great resource for others because, as always, we record this and we put it on our website, and we want to definitely share it out widely. So, thank you, everybody.
Great. Thank you so much. Have a great day.
You too. Bye.